Hello. Hello.
Yes, sir. Yes, sir. We are hearing you. Please go ahead.
1 minute. Yeah. Good evening, all of you. Hello.
Yeah, good evening, sir.
Can you hear me? Okay.
Yeah, we are able to hear you.
Okay. Good evening, all of you, for today's
Can you
session
see
on
us?
cardiology. It is going to be very interesting.
I know, but I don't care.
You are muted, Dr. Surendranath.
You are muted, sir. Initially you are heard, now you are muted.
Continue it.
धरा की बात करते हैं, पवन की करते हैं, सृष्टि की बात करते हैं. धरा पाठ होने पास.
Sir, unmute yourself, sir.
Hello.
Unmute yourselves.
Surendranath, unmute చేయండి మీరు.
Yeah, you can start, I think. Yashowanth.
Okay. Yeah, sir. Welcome all to this program of interesting cases in cardiology. We have a renowned faculty here. I thank Dr. Nageshwar Rao directly. Though he is not here, he has seen that the program goes on. So today we have Dr. Swetha Bhakru, who is be the moderator. We have Dr. Bhargavi, Dr. Pooja, and Dr. Vinod Dorai Swami from Coimbatore will join. I acknowledge the presence of Dr. Srinivasan, former director Jitmer, who has lot of interest and who was instrumental in running the cardiology from 1977 onwards till the day he deannuated. So welcome, sir. We are fortunate enough to have our faculty. Vinod also has joined in.
Hello everybody.
Yeah, all the team is the team of care, and now the Rainbow Hospital. We are fortunate enough, they are the pioneers in this field. I hand over the mic with this few comments that let us have a learning and enjoy the academic feast. I'll hand over the mic to Dr. Lakshman and then followed by Dr. Sridhar to introduce today's speakers. Dr. Swetha Bhakru will be the host, will be the moderator, and we have 3 cases today: unexplained LV dysfunction, bradycardia in a newborn or infant, and third we have one more case which will be discussed. So over to Dr. Lakshman Garlapati.
Yeah. Thank you, Dr. Yashowanth. And good evening, all the participants and all the faculty members. And welcome to this 4th webinar from PATS. So this is the 4th webinar on this month in January. And I thank Dr. Yashowanth for inviting to chair this session, interesting cases in pediatric cardiology. And now I would like to introduce Dr. Bhargavi and Dr. Pooja. Dr. Bhargavi Dulipadi. She's a pediatric cardiologist. Hello.
Yashwanth,
Somebody
please switch off. Mute them.
Hello, Dr. Bhargavi Dulipadi. She's a consultant pediatric cardiologist in Rainbow Institute of Cardiology at Hyderabad. She did her MD, DNB, and FNB in pediatric cardiology. And her areas of interest are fetal cardiology, management of arrhythmias, and cardiac genetics. And Dr. Pooja Sinha, again, she is also from Rainbow Pediatric Cardiology Institute, Hyderabad. She did her MD, DNB in cardiology, and her fellowship in Canada in MRI, pediatric cardiology. She is an associate pediatric cardiologist at Rainbow Hospital, and her areas of interest are grown-up congenital heart diseases and cardiac MRI. So I invite both of you to this session, and I hand over to Dr. Swetha Bhakru and Dr. Sridhar, and later on to Dr. Swetha Bhakru to moderate the session. Over to Dr. Sridhar. Yeah.
Thank you, sir. First of all, I thank Dr. Yashowanth and Dr. Surendranath sir for giving this opportunity as a chair for today's session. And definitely there are 3 interesting cases of cardiology, pediatric cardiology. And let me introduce today's moderator, Dr. Swetha Bhakru. She's a senior consultant pediatric cardiologist working in Rainbow Children's Heart Institute, Hyderabad. And she had more major achievements, honors, awards, and publications, and 20 publications in national and international journals. So many articles were given in the textbooks of chapters of IAP, and she is also examiner to DNB and pediatric cardiology and DNB assessor. And she had more interest in fetal cardiology, physiology, and innovation. And coming to the other expert, Dr. Vinod Doraiswamy. She is senior interventional pediatric cardiologist, done MBBS, MD pediatrics, and MRCPH from UK, and fellow in pediatric cardiology from UK. And present employment is working as in KMCH, Coimbatore, Tamil Nadu, till date. And he worked in PSG hospitals, Coimbatore, and Care hospitals, Hyderabad. And he underwent pediatric cardiology training, Madras Medical Mission Hospital and Southampton Journal, UK. And pediatric training MD is in Seth GS Medical College. And special interest is in pediatric and adult structural interventions, ASD, VSD, PDA, and AP window. There are so many special interests for Dr. Vinod Doraiswamy. And 2D and 3D thoracic and transthoracic transesophageal echocardiography is a specialist in that. And he had more publications and research, and is in very much regular teaching activity of students and nurses in all these webinars and other things. And I request Swetha Bhakru as the moderator today take over and start the session, madam. All the best.
Thank you so much, sir. The esteemed faculty from IAP, thank you so much for allowing us to be part of this PAT program. We conducted this last year also during the pandemic, and it was lot of discussion, academic discussion happened during this platform. So I'm sure we'll continue the same legacy, and we'll present our interesting cases by our 3 esteemed consultants. They all are basically a good clinical cardiologist, and that's why we could come to a conclusion to various heart diseases which have been presented today, and how the clinical presentation and thinking changed the management in all of these cases will be the highlight during this discussion. So I will start with Dr. Pooja, who will present with the case of a bradycardia in an infant. Although this is one of the rare presentation in infants and often can be overlooked, but her presentation will definitely highlight that how the importance of ECG is, and clinical presentation thinking towards the various etiology can change the management in these cases. So I'll hand over to Dr. Pooja. You please go ahead.
Thank you, Swetha ma'am. I'll just share my presentation and start. Very good evening, everybody. And I'll start off this series on this beautiful Friday evening with the first case on an infant with bradycardia. So this is when we'll be discussing when we come up with the diagnosis of complete heart block. This was an interesting clinical case, especially the clinical aspect of it and the management decision. And the best part was the very gratifying outcome that we had at the end. So this was an 8-month-old boy who came to us with a history suggestive of heart failure. There was a history of recurrent vomiting and decreased activity over the last 5 days. And the baby had respiratory distress for the 2 days before admission. There was no history of fever or exposure to COVID that they could identify. The patient's parents could not really give any definite history towards that. However, they did report that the boy had a recent upper respiratory tract infection about 2 weeks ago, but had apparently recovered from that. There was no other significant past history. There was no family history of childhood onset heart disease, and the elder sibling was a healthy 3-year-old boy. On admission, examination showed us that the baby was afebrile. The baseline heart rate was low at 40 beats per minute. There was a mild resting tachypnea. The baby was acyanotic. We did some baseline investigations. We'll come back to that. The ECG that we went on with our cardiac evaluation, the first step is usually the ECG. So I'll use my pointer. Right away, we see that the QRS complexes show us a very low baseline heart rate. That was around 50 beats per minute, the QRS, the ventricular rate. We see P waves here, 1, 2, 3, then a narrow complex QRS, 1P, 2, 3, 4, then a QRS. Again, 1, 2, 3 Ps, then a QRS. So it's basically AV dissociation with a narrow complex ventricular rate of around 50 per minute. That is regular. So complete AV dissociation and a regular RR suggestive of complete heart block from the ECG. We went on to do the echocardiogram. Right away, we see that the heart rate is obviously low for an infant. We see this is the apical 4-chamber view. We see that there is a definite arrhythmia that is evident right away. We see that there is regurgitation that is there at the tricuspid valve on the right-hand side over here. And this is usually the pattern that we get when we have atrioventricular dissociation and there is an arrhythmia. Because of the dissociation itself, there will be an underlying AV valve regurgitation that we can see on echo usually. However, the squeezing or the contractility of the heart appears to be normal here. We'll confirm that from the parasternal short axis of the ventricle. This is the left ventricle, and we see that the squeeze of the ventricle, that is the systolic function, appears to be preserved. However, we again notice that there is definitely a bradycardia here. The heart rate was again around 40 to 50 per minute. Also, when we did a subcostal sweep and we look at, these are basically the domes of the diaphragm, and we see that there is actually a moderate pleural effusion on the right side and a mild pleural effusion on the left side. So there appears to be a systemic involvement here. Other pointers to inflammatory etiology, and now we'll go back to those blood investigations that we did at the baseline. So there was a definite increase in the total count and the platelet count, and the troponin I that we sent out was found to be raised. So pointers to inflammatory etiology in this case with the inflammatory markers that were elevated. There was bilateral mild pleural effusion and moderate on the right side, and that recent history of upper respiratory tract infection that the parents reported. Till now, the baby had subtle features of clinical heart failure. However, during the admission, the baby continued to deteriorate clinically, went on to have progressive respiratory distress, needed to be shifted to the ICU. And that was when we decided that in addition to anti-inflammatory therapy in the form of IV immunoglobulin that we gave at 1 gram per kg, we would go ahead with the temporary pacing to stabilize the baby for then. So this is an X-ray that was done after the temporary pacemaker. You see that temporary pacemaker lead going in by the IVC. This is the right atrium and lodged in the right ventricle. And then the baby was put on a heart rate of 100 and an output of which was then continued. We decided to watch the baby for a few days and see how the baby behaved after the anti-inflammatory therapy was initiated. The baby was posted and they were told about the possibility of the need for a permanent pacing. However, we had decided that we would reevaluate it before reevaluate the baby before we went ahead with this course. This is an echo that was done before the child was actually at the end of a week, actually, after the anti-inflammatory therapy. And surprisingly enough, and really happily, this is the picture that we got. This is after, this is when the temporary pacing was taken off. And right away from the echo, we see that there is a wonderfully increased heart rate. That distinct arrhythmia that we noticed on the first echo is no longer there. There seems to be atrioventricular synchrony here. We see that prominent regurgitation that we had seen because of the dysynchrony on the tricuspid valve is no longer there. That pleural effusion that we noticed on the first echo is now no longer there. So the baby has actually responded well to the anti-inflammatory therapy. This is the ECG that we did, and this is after a week. And we see that now the P and the QRS is now following one another. So although there is a baseline sinus bradycardia, there is PQRS concordance and there is synchrony now. And this actually improved over time, and the heart rate also picked up with an average of around 100 per minute. There is PQRS, and there is now normal sinus rhythm. So this was a case that happily went on to a good conclusion. The pacing helped to temporize and stabilize the baby till the anti-inflammatory therapy could reverse the features of complete heart block that the baby had presented with. So the discussion that we go on to from this is, although like Swetha ma'am pointed out right in the beginning, complete atrioventricular block is a rare presentation in infants and children. The first thing we need to consider is whether this is congenital versus childhood AV block. The reason behind this is that the etiologies behind congenital and childhood AV blocks are completely different. When we think of congenital AV block, we think of autoimmune, and we think of SLE and lupus and maternal autoantibodies being transmitted. And when we think of childhood AV blocks, although a small component of those patients can also present late in childhood, a lot of these are acquired. So one big component of childhood AV block is when we start looking for structural heart disease, because a lot of congenital heart disease itself can be associated with AV blocks, like we very well know. Complete congenitally corrected transposition is one. Epstein can have heart block. AV septal defects can, atrioventricular septal defects can have heart block. Then if there is a structurally normal heart, the next question becomes if there is actually any reversible cause for the complete heart block, in which case temporizing measures and temporary pacing become crucially important. So whether to pace or not, whether the child is symptomatic because of chronotropic insufficiency or not, becomes the next big question. And the role of supportive care and anti-inflammatory therapy. So potentially reversible causes of childhood complete heart block that we need to think about whenever we are dealing with any cases like this is an acute or chronic, any acute or chronic infectious process like myocarditis, even acute rheumatic carditis, although we usually associate this with first degree or second degree AV block. Very rare cases may present with complete heart block also. There can be hypersensitivity cardiomyopathy. Hypothyroidism is a reversible cause. Even coronary artery disease, even Kawasaki disease can have complete heart block, just like many arrhythmias in the acute phase. Some part of it may be due to the underlying myocarditis component, and some due to an abnormality in the AV nodal microcirculation that can happen. And even prolonged neurological issues or pathologies can actually cause conduction abnormalities in childhood. So in conclusion, looking at complete heart block, a lot of my friends still say that when they're faced with a baby with bradycardia, their own hearts seem to stop, but that is not the way we go ahead with this. We need to think, we need to categorize, we need to classify, and try to manage based on the etiology, temporize, stabilize, treat the etiology if possible, and then go ahead and hopefully get a happy outcome like this with a well-contracting heart and a good heart rate. Thank you.
I thank you so much, Dr. Pooja. It was the wonderful illustration of a bradycardia because of complete heart block in a child. So what we have learned till now is a complete heart block in an infant who is symptomatic is most likely due to maternal SLE transmission. And some of them, they escape the neonatal phase during the symptoms, and later during infancy, they can be presented. And then they usually require pacemaker. That's what we have learned. But what was strikingly different in this case, as Dr. Pooja has pointed out, that there were inflammatory markers which were elevated, and there were bilateral pleural effusions. So usually pleural effusion goes with the, because of the some kind of inflammation, like it can be due to dengue fever or rarely due to diphtheria, where diphtheria myocarditis can happen. And all this infectious and inflammatory process can lead to a complete heart block. And before keeping any child listing towards permanent pacemaker, we should always think, is there an acquired cause for this complete heart block? And like in this case, he has completely recovered and did not require pacemaker. So probably on the ECG, we can see sometimes the pointers like, broad QRS, rhythm, and if there are runs of VPCs, these are classical examples of diphtheria myocarditis, and diphtheria myocarditis can lead to complete heart block. We have seen a couple of patients where they were not vaccinated and led to the complete heart block in them. And usually we should rule out dengue, diphtheria, and inflammation. And now because of the COVID, we are seeing all kind of presentation. So we thought whether this was, a rare type of inflammation process due to post-COVID reaction. We didn't know that. So I think wonderful illustration. If there are any questions, we can take. So I think there was one question in the chat box that mother during pregnancy, no SLE. This was the question they asked. Do you want to take this, Dr. Pooja?
There was no definite history of maternal SLE, but saying that a majority of patients with babies with heart block actually do not have, the mothers do not have overt connective tissue disease. There were evidences of inflammatory involvement here. So if we were thinking of idiopathic heart block, that would have been one of the investigations to go ahead with.
Yeah. I agree with that, because there can be recurrence in the next pregnancy. So we should screen always mother, and most of the time the mothers are asymptomatic. So the next question is, what are the electrolyte abnormality beside hypokalemia and hyponatremia causing CHB? So obviously electrolytes should be checked in any kind of tachyarrhythmia or bradyarrhythmia. So your call on this, Dr. Pooja.
Not complete heart block as such, but magnesium is sometimes involved in.
Yes, it can cause bradycardia. It can cause long QTC, hypomagnesemia. So very important. We don't send that investigation, but magnesium is the very vital electrolyte for having normal conduction of the heart. And in a brief, would you like to tell that how would you do the workup of complete heart block patients? A new onset complete heart block patient.
When a baby presents with us first to complete heart block, the first thing that you would check for is structural heart disease, because structural heart disease and even interventions for structural heart disease like surgery or cath interventions are worldwide the most common cause for complete heart block in childhood. So in a structurally normal heart, like we said, the reversible causes are what we need to rule out. So as a baseline, we would look for maybe evidences of past infection, like for now, COVID antibody positivity is a big thing because multi-system inflammatory system in childhood is one of the big causes of arrhythmias unexplained in childhood right now. We would look at serum electrolytes. We would look at the other inflammatory markers, especially if there is a background of myocarditis. So troponins for elevation. Other than that, if we find that these are negative, then the next step would be to look for maternal autoantibodies and rule out maternal SLE. Beyond that, Ma'am, anything that you would like to add? You're muted, ma'am.
Yeah, electrolyte disturbance or any infection like diphtheria, dengue fever. I think this should be any reason for myocarditis. And sometimes, the infective endocarditis of the mitral valve that can erode into the AV septum, and unruptured abscess can lead to the complete heart block. So again, the infection at the level of mitral valve should be seen. Aortic valve root abscess can erode into the AV conduction, and unruptured one can cause the heart block. Rarely unruptured RSOVs can lead to heart block. So these are all rare causes, and we must look into it. So hypothyroidism is one entity. They asked that whether can it cause a reversible block. So I think it can cause sinus bradycardia, extreme degree of sinus bradycardia, and it will be very narrow height, less than 5 mm voltage of QRS complexes will be seen on ECG. And we have seen actually the bradycardia cases with extreme degree of hypothyroidism. So any your take on hypothyroidism, Dr. Pooja?
I personally haven't seen any complete heart block, but it is listed as one of the very rare causes. Sinus bradycardia for sure, yes.
Yeah, any parasitic infection. So I think
there's
yeah,
lots of non-Indian causes, Lyme's and all of that is discussed a lot.
Yeah, like Chagas disease.
Chagas, yes.
This to involve the cardiac involvement is known to happen. However, we have not seen, but I think we have to keep all these possibilities in mind. If the inflammatory markers are elevated, if you're finding pericardial effusion, pleural effusion, and if there is a systemic involvement, then all these things should be kept in mind. So Dr. Vinod is ready with the next talk, and I'm very happy to invite Dr. Vinod. Thank you for joining this team. And he's always handy. He's one of my colleague who has been working closely associated with us. And now he's at Coimbatore. I request Dr. Vinod to go ahead with his talk. His talk is the small airways and there is a large heart. So what can be the clinical presentation and how to manage that? So large heart and small airways. Please go ahead, Dr. Vinod. Thank you.
Thank you, madam, for the introduction. I'd like to thank Pat also for giving me this opportunity to present in front of all of you. I think I'm host disable my participant screen sharing. I'm not able to screen share.
Pooja, can you disable your share screen? Then he will be able to do it.
I've stopped my share screen.
Yeah.
Now I think the host has to allow share screening.
Okay, can you do now?
Yashowanth?
No, it's still not working.
Kindly, Vinod, we make co-host or host.
Yeah. So
yeah,
now
so,
can you see that?
Yeah.
Vinod, you are made co-host now.
Thank you.
You can share now.
Just a minute. Dr. Pooja, that was an excellent presentation. Really enjoyed it. Did you see? So basically, we are thinking that it's some non-specific viral infection and the inflammation which caused this?
Yes. We couldn't pinpoint, but yes.
Yeah, we thought same way actually, Vinod. We thought maybe it's a kind of post-COVID illness because he responded to IVIG.
I was thinking like maybe elder children, we should think of sarcoidosis also. They can
Dr. Vinod,
infiltrate.
Your screen was showing your WhatsApp things.
I think now is it my slides are seen?
No. Your WhatsApp screen was open, not your presentation.
Yeah, it's not seen.
Oh, okay.
You have to go back and press the
Okay, I'll try one more time. Desktop.
We're able to see you, Vinod.
Okay. Once again, thank you, Pat, and for giving me this opportunity. So my case is large heart and small airways. So I'm recently moved to Koi Medical Center Hospital, Coimbatore. You can see the hospital in the background, where I'm working as a consultant interventional pediatric cardiologist. So this was a 6-month-old child with history of cough and cold with mild respiratory distress for the past week. And on probing the history, they gave not a very definite history, but somewhat a suck cycle from early infancy. Other than that, we did not get any other significant history, no fever, no previous admissions for LRTA or forehead sweating, no cyanosis or cyanotic spells. So, booked and immunized, anomaly scan was normal, born 3 kilos, development was normal. So the baby has been normal till now. So if you want to go for the diagnosis from the history, we know that this is maybe a bronchiolitis and LRTA, but with the suck cycle from infants, from early infancy, we might be thinking of this is the commonest way left heart failure presents in infancy. So the commonest cause of left heart failure will be a shunt lesion. So the acyanotic heart disease with increased pulmonary blood flow, like a post-tricuspid shunt, like a VSD or PDA. And very rarely, if you have a anything which can cause increased pulmonary venous or LA pressures, for example, a left heart failure due to dilated cardiomyopathy due to whatever cause, or myocardial disease, can cause these symptoms. So on examination, child was bright, active, and alert with mild tachypnea. Vitals were okay, 130 per minute, mild tachypnea 60 per minute. Femurs were normal, there was no gallop rhythm. So quite a well-preserved child. So why we were called, why we were called is because when the X-ray was done, we could see that there was a huge heart on the X-ray, which we didn't expect. So we got a call. So you can see there's a huge heart over here with a normal pulmonary blood flow. And then you can see there's the angle between the heart and the diaphragm is not an acute, it's an obtuse angle. So we think that the left ventricle is enlarged from this. The lungs seem okay at this point of time. So the ECG shows very characteristic findings. If you go and see carefully, you can see that you have Q waves in 1 and AVL and Q waves, deep Q waves in V5, V6, which is the first negative portion. And those corresponding leads have T wave inversions and ST depressions. So most of you might already know the diagnosis. So we proceeded with the echo at that point of time. So you can see there's a huge heart. This will be the left atrium and left ventricle. And the soft marker of the diagnosis, which is Al Kappa in this case, you see for the mitral valve and all these is the papillary muscle and chordae. So due to the infarcted myocardium, it will be hyperechoic or glistening. That's due to the infarction and fibrosis. So this is showing the hypokinesia of the LV. So if you see carefully, the lateral walls, the movement of the lateral walls is much less than the medial wall or septal wall. That is because this is the part which has been infarcted. So when we go to see the coronaries, this is the still image. This is the aorta and the pulmonary artery. So normally you know that the coronary arteries, this is the left coronary artery, should arise from the aorta, but here it is arising from the pulmonary artery. And when we see the Doppler flow, the red means it's going towards the probe. So there's a reversal of flow from the left main coronary artery into the pulmonary artery, which means that the coronary blood is stealing away from the LV myocardium, which is causing the myocardial infarction and the huge heart in this case. So the diagnosis will be now anomalous origin of left coronary artery from the pulmonary artery, or Al Kappa, as we call for short. So this child was treated for bronchiolitis, taken up for surgery after a week. Generally, what they do is they reimplant the left main coronary artery from the pulmonary artery to the aorta on cardiopulmonary bypass. So because these patients have LV dysfunction, they are known to have a stormy post-op course. So this child had a low cardiac output syndrome. There were some fever spikes, high inflammatory markers. We had to upgrade the antibiotics. So we had a difficult time getting this child out. And this is the echo showing post-op, where you can see now the coronary arteries, instead of coming from the pulmonary artery, they're coming from the aorta after reimplantation. And these are good flows now. The blue flow showing that the flow is going from the aorta to the coronary artery. So the patient recovered with regard to his hemodynamics, but unfortunately failed to 2 extubations. And clinically, there was decreased breath sounds over the left lung. So now when we see the X-ray, we see that huge heart, but we see the left lung is totally like collapsed. It's like a whiteout of the left lung. So at that point, we thought maybe some mucus plug is maybe obstructing the left bronchus, which is quite common in infants who undergo surgery or if infants are on ventilator. So we did a bronchoscopy thinking that we might be able to extract that mucus plug and help this baby get out of the ventilator. But doing the bronchoscopy, we found that this part is the left main bronchus, so it is completely compressed. So there's an extrinsic compression of the distal left main bronchus, causing greater than 90% luminal narrowing. So we wanted to know like what is compressing this left main bronchus. So when we did the CT, you can see that this is the left bronchus we're tracking over here, then it disappears, and you can see the distal bronchus, and that is the part where it's compressed, and you see it is compressed between the huge left atrium, which this baby will have due to the LV failure, and there is anteriorly and posterior is the descending aorta. So this left main bronchus was obstructing between the left atrium and the descending aorta. So this is the HRCT showing the left lung, which is completely collapsed and consolidated along with the air bronchogram, and the aorta, which is showing the coronary artery is now arising from the aorta, which is flowing well. So then we were discussing what will be the best management. So we went through the literature, and it was suggested that if the bronchus is compressed by a vascular structure, in this case the descending aorta, it will be better to do a surgically aortopexy, where we take the aorta and turn it around posterior and suture it to the vertebrae behind. So we take the aorta away from the left main bronchus so it doesn't compress. That will be better when the bronchus is obstructed by a vascular structure than doing a bronchial stenting. So bronchoscopy in the CTOT confirmed patency up to the segmental bronchi, and then breath sounds improved over the left lung. And now you can see that the left lung is nicely expanded over here with good blood flow. So we were able to extubate the baby after 2 days and discharge after 3 days, and continues to do well. So coming to a little things about Al-Kappa, it is also known as Bland-White-Garland syndrome. So initially these patients are fine in fetus. Reason being the pressures and the saturations are equal in the aorta and the pulmonary artery. So in fetal life, they'll be same, will be fine, even though the coronary artery is arising from the pulmonary artery. But after birth, will fall in the pulmonary vascular resistance. The coronary artery starts stealing blood away from the LV myocardium into the pulmonary artery, and that is when the infarction happens. 90% will die by the first birthday, and very rarely 10% can survive to adult life if they have well-formed collaterals coming from the right coronary artery. So this is the Al-Kappa picture diagram. You have the aorta giving rise to the right coronary artery and the pulmonary artery giving rise to the left main coronary artery. So this is in fetal life. So because the aorta and the pulmonary artery have the same pressures, the pulmonary and the same saturation almost, the pulmonary artery is able to perfuse blood. See, the direction of blood flow is towards the myocardium. So infarction doesn't happen. But we know after the baby is born and takes the first breath, the PVR starts dropping and comes to the adult level around 4 to 6 weeks of life. So that is when because the PVR has dropped now, the blood now starts going in the reverse direction from the LAD to the left main coronary artery back into the pulmonary artery. So it's stealing blood away from the LV myocardium. So it causes a myocardial infarction. So usually the right coronary artery, to help out, will give collaterals which will try to supply blood to this infarcted myocardium. So depending on how good or big these collaterals are, that is how the baby presents. So if the collaterals are not good enough or not big enough, they'll present with myocardial infarction and heart failure, like this child around 4 to 6 months of age. But some of them who rarely persist beyond the first birthday will have good collaterals. Some of them can even reach adulthood with good function. Those are the ones who have good collaterals from the right coronary artery, compensating for the left coronary artery blood flow. So usually presentation is between the 2nd to 3rd month of life, diagnosed by ECG and X-ray. So usually many times ECG is done by our friends, and then they even suspect a diagnosis of Al-Kappa and then send to us. So we're very happy when that happens. Treatment is by surgery, reimplantation as soon as possible. And prognosis is good if recognized early, especially if the mitral valve is not that much infarcted, the papillary muscles, and not much mitral regurgitation. Many can attain normal LV function by 1 to 2 years. So coming to congenital heart disease and airway problems, which is the crux of our topic. This was just a study taken from Korea where they examined 2,729 patients with congenital heart disease, and they found airway compression in 2.1%, which they evaluated by CT scan. The main place was the left main bronchus, and they divided into 4 groups. The first was the rings and the slings, and the second was the arch lesions like coarctation of aorta and interruption of aorta. So what happens is when they get repaired, the distance between the ascending and descending aorta decreases, so they cause mainly the bronchus obstruction after the surgery, whereas rings and slings will have before the surgery. Shunt lesions, like for example a VAC or PDA, there's increased pulmonary blood flow, so pulmonary arteries are dilated, they can compress the left main bronchus. What they have found is that if you just treat these, only repair the congenital heart disease, the pulmonary artery size will decrease in time, and they don't need a separate surgery for the main bronchus obstruction. So as I said, Group A and B needed additional airway relieving surgery either during or after the surgery. Group C, that is the shunt lesions, needs CHD repair alone. In addition, there was another Group D called as the miscellaneous, like for example, Epstein's anomaly or TGAs, for example. And so some of them needed surgery and some of them did not. In that Group D, there was actually no cases of Al-Kappa were there. So maybe main bronchus obstruction is quite uncommon in Al-Kappa, like in our case. On going for the review of literature, we were able to find only one case. It was a 10-month-old child who had presented, first presentation of a 10-month-old child with a pneumonia which was not resolving. X-ray showed a whiteout left lung and CT showed a left main bronchus. So the patient deteriorated during CT scan. So at that time, they did an echo and found Al-Kappa. They stented the left main bronchus because the child was very sick. And after the child improved, they went for the Al-Kappa repair and did well after that. So that was the only case which we could find out. So closing thoughts will be Al-Kappa is one of the uncommon causes of dilated cardiomyopathy, which is correctable. So it's important that this has to be ruled out. ECG gives us clues towards diagnosis of Al-Kappa and should be done in every case of a dilated cardiomyopathy. Coronary arteries should be checked in every case of a dilated cardiomyopathy echo. And if diagnosed and corrected as early as possible, many can attain even normal LV function. With regard to compression of airway, they should be suspected in any congenital heart disease, especially when the chambers get dilated. Like for example, LA, as they can compress the bronchus. Many of them can present with wheezing, bronchiolitis, hyperinflation, or whiteout lung atelectasis. But I agree that these are also non-specific symptoms. So you just have to suspect and go ahead. Proper evaluation should be done so that airway compression surgery can be planned during the surgery. Most left to right shunt lesions don't need airway compression surgery. Excuse me. Al-Kappa is the rare cause of airway compression. So coming back to our pre-op chest X-ray, when we went back and saw, if you can see actually the trachea is going and dividing to the right main bronchus. You can see the left bronchus is seen up to here, but then it is slightly cut off. So this is corresponding to the corresponding to the CT scan where it shows the left main bronchus being obstructed, and you can see distally over here. So maybe this is a point that we had missed. Maybe if we had found whiteout left lung, we would have gone for a CT beforehand and done the aortopexy at that time. But it just shows that every single point has to be noted when you're going for such a complex heart surgery, so that we can avoid these things in the post-op. Thank you very much for your patient hearing.
Thank you so much, Dr. Vinod. It was wonderful display of, one of the disease which can be missed commonly. And time and again, we have said that, all LV dysfunction are not viral myocarditis. We have to have list of diseases. We have to go ahead and look for diseases like Al-Kappa and LVOT obstruction, coarctation of aorta, hypertension, any electrolyte disturbance, renal parameters, and treating them is really so much gratifying and rewarding because you can come back to normal ventricular function. And as you have correctly mentioned that, airway problems are known to us post-op. Machine in a calmer way. So all those things really matter, picking up the case of Al-Kappa.
Thank you.
So if there are any questions we can take.
I would also like to say one thing, like in many places, maybe peripheries, they might not be pediatric cardiologists, they might be adult cardiologists only. And many of them might not be used to looking for Al-Kappa. So I suggest, like, if you send to them, you can write, please look for coronaries. When you send for a case of, you see a X-ray with a huge heart, kindly look for coronaries. And then, like, maybe they might see and okay, we'll look for the coronaries, or send to somebody if they're not able to see. So that would also be a good strategy as well. So we can miss these cases because they're completely correctable and they can even come to normal LV function. and the quality of life will be very good if picked up early.
So if there are any questions, we can take, or we'll move ahead with, our next presentation. Bhargavi, have you joined?
Yes, yes, I have joined.
Okay. I'm so, happy to introduce my colleague, Dr. Bhargavi. We are so closely associated with each other in hospital. Each clinical case we discuss time and again, we take each other's opinion. And, I feel it's a combined team approach that we deliver to the patient. And that's why probably we have such a gratifying results. So, Dr. Bhargavi, over to you. Can you please go ahead and present your case?
Yeah, I miss that team approach, madam, actually.
You're always there in team, Vinod, anytime.
You're always there, sir.
Thank you.
You're part of team.
Good evening, everyone. Excellent presentation, Vinod, sir. Identifying airway obstruction post-operative.
Make it full screen, madam.
Yeah, it's in full screen, sir. Able to see, sir? Full screen?
Yeah,
full
we can
screen,
see.
yeah.
We can see,
Yeah.
Bhargavi. Please go ahead.
So today we are discussing an interesting case of unexplained heart failure. So we have a 9-year-old girl who is actually resident of Hyderabad, went to Guntur for a function, and after attending that, she had vomitings, abdominal pain, and it was continuous for a week, treated by the pediatrician there. And later, after 3 days, she started having dyspnea and went to like grade 4 dyspnea, and orthopnea is also there. Admitted at a local hospital, and there it was congestive heart failure with pulmonary edema and EF of 60%. So there what they have seen is there is a hemoglobin of 8.9 and WBC counts were increased, platelets were 2.5, the inflammation, CRP is increased, ESR is increased, and it's COVID antibody positive. And as a routine, as all we are doing, they did a D-dimer. D-dimer is also 1500, which is elevated. So at this point of time, seeing everything, they have treated as an MISC and received IVIG 1 gram per kg per day. So that is at that point, the diagnosis is MISSI. Then next coming, so after a week, the child presented to us. She is very sick looking, feeble pulse. We are all not able to palpate the pulse. And here we can see the blood pressure chart of all the limbs were low. And the saturations were 90% at 2 liter oxygen. There is LVS3 gallop. There is epigastric tenderness. When we want to palpate her, she is not allowing. She is conscious and there is a hepatomegaly. So we have a 9-year-old child with pulmonary edema, congestive heart failure, and saturations of 90%, and all the blood pressures were low. So then the X-ray, it showed definitely cardiomegaly is there, and then pulmonary edema is also there. So our labs showed like hemoglobin is same, there is anemia 8.9, the WBC counts of 21,000, platelets of 2.7, CRP 67, ESR is 82. So at this point of time, we have done the ECG. So when you see the ECG, definitely it's a sinus rhythm. P followed by QRS complexes are there. And PR interval is also normal at rate of around 100. But if we see the ECG clearly, then there is LVH pattern. So V5, V6, there is an LVH. So here we had a doubt why the LVH is there in this case. So then echo revealed severe ventricular dysfunction, and also you can see there is a ventricular hypertrophy is present, and coronary arteries, as they have they have told, it was of normal size. And the ejection fraction at that point of time is around 30%. So here 9 years girl child presenting with heart failure with pulses, means blood pressures are very low in all the limbs with LVH. So here we should think other side, what is causing LVH and why the pulses are not there. So then we actually palpated all the 4 limbs pulses are not present. So here in the first video, we can see it's an arch view where there is a turbulence at the subclavian artery. This is the turbulent part of the subclavian artery, and this is the Doppler showing the subclavian artery turbulence and gradient. And next video is also showing, this is a descending aorta Doppler where you can see the turbulence there. And the Doppler of the descending aorta is like a continuous waveform, which should not be there. So now coming to this, then the diagnosis is when we went back and auscultated her. When we auscultated at the abdomen, there is a bruit. So this is a case of Takayasu arthritis, which presented as a heart failure and pulmonary edema, because in our COVID era, we have mistaken it as a MISC and treated for the IVIG. So whenever you have, like, as Dr. Vinod sir told about the Alcapa, we have to see the treatable causes of cardiomyopathy and LV dysfunction, and we have to go back and see, are we anything missing? Like here we missed, like, all pulses are feeble, not at all palpated. All the pulses, only right upper limb pulse was just palpable. And then there is an abdominal bruit, which we have never palpated anybody. So that is a clue actually for the clinical diagnosis of Takayasu arthritis. So I'm very sorry, I don't have the CT angio, but the CT angiogram showed the descending aorta, thoracic aorta, there is a luminal irregularity and narrowing of the descending aorta. And that is the reason your lower limb pulses are not felt and blood pressures are low. And next is the left subclavian artery. There is an ostial stenosis of the left subclavian artery, and also the right subclavian artery is also significant ostial stenosis. That is the reason there is no right hand pulse and there is no left hand pulse. So if you don't have any pulse, we think blood pressure is not recordable or low blood pressures. Still, the child is hypertensive because your central aortic pressures are very, very high. So this is the guidelines to a 2022 American College of Rheumatology to identify the Takayasu arthritis. So in this, there are the criteria are there, and in that, like female sex and any chest pain, arm claudication, vascular bruit, which is there in our case, and reduction in the pulses of upper extremity and systolic blood pressure difference. These are all the criteria which tells about the Takayasu arthritis. So at present, the diagnosis of Takayasu arthritis. So next, what is the management? So whenever you have a Takayasu aorta arthritis, we should see the inflammation. How is the child is in active phase of inflammation or in the remission phase? So when the child, and before that, we should do MANTU for all the aorta arthritis in India, so that we have to rule out the tuberculosis. In this child, MANTU was negative. And when we saw the CRP, so this is 67 is elevated and ESR is also 80. So then what we have done is we have on oxygen very high, and we can only assess either through catheterization or sometimes in the echo. If you have a mitral valve regurgitation, we can assess the gradients. So here again, we started on diuretics, we started on antihypertensive. Along with that, because as the child is in active phase, we started on steroids. At that point of time, we did not start on cyclophosphamide this child because creat was high and renal involvement is there, 1.8. So mycophenolate mofetil was started, MMF was started, and gradually the CRP came down, but this ESR is still high, 54. So gradually steroids were made first IV and then to change it to oral, and clinically there is an improvement in the child, and child epigastric tenderness was decreased. Actually, if we go back to CT, we have the SMA, some regions of celiac axis involvement is there. So when you see the aorta arthritis, they will, most of the time they will complain of abdominal pain also because of the involvement of celiac axis and SMA that we have to see further. So then child was clinically better. As the child is in active phase, we should not go and intervene in the active phase. We have discharged the child. So then after what happened? After 2 weeks of, we are in close follow-up. Every 3 days we are seeing the child. And after 2 weeks, still the ESR was like in 20s. And child came with a hypertensive encephalopathy. means child was encephalopathic and had a seizure activity. So now it's like an emergency situation where you cannot wait with all the medications. We have to go and intervene. CT brain was done because of the seizure activity. It was normal. Then we have taken the child into the lab. This is an angiogram where we have kept a pigtail catheter from femoral artery descending aorta, and this is the constrictive part of the place. And when we have seen here, pressure difference was taken. In this parallel one, it shows like this is the aortic pressures, ascending aorta pressure. So as I told you, there will be central hypertension. We can see it is a pressure here. Pressure is 164 by 100. And the lower down pressure is 118 by 94. So this pressure we have taken, and when we did the angiogram, there is a discrete luminal narrowing of the artery, thoracic artery. So then we went and did balloon dilatation, because as the child is very hypertensive, encephalopathy and seizure, as a emergency procedure, life-saving procedure, we have to go ahead and do the balloon dilatation. This is a 7 into 60 mm Cook balloon. Serial dilatations were done very slow, gradually. And then post we can see there is definitive increment in the size of the lumen of the descending aorta. And we can see, as we see the initial one pressure curve, there is lot of gradient is there, 160 by 120, almost 45-50 gradient. But when you see here, almost both the pressures came into same line. There is around 10 gradient is there. That means we have achieved our clinical target of improving the lumen. Here we are doing sequential balloon dilatations only to increase the lumen of the aorta and make the child symptomatically better. After this, the LV function, as gradually on follow-ups, the gradually LV function is improved. Still, child is on oral steroids and disease-modifying agents, but the LV function was improved, and now presently the LV function is around 54%. So we can see here also the descending aorta, which was continuous flow in the first panel when the child came to us. Now there is some pulsatility is there. So this is about the Takayasu arthritis, which we have a child where initially thought due to COVID era and COVID antibody and D-dimers that it's an MISC. And later we understood like it's aorta arthritis, and mainly we should not miss our clinical findings like pulses not palpable, pulseless disease, it is called as a pulseless disease, and bruit in the abdominal aorta should not be missed in any case. So coming to the management, we discussed about the protocol, how we have diagnosed, and mainly the management should be on steroids, and then we have like azathioprine, methotrexate, and cyclophosphamide. Based on the other organ involvement like renal, we have to take the medications. And now the disease modifying agents like TNF-alpha inhibitors, infliximab, tocilizumab is also mainly used in these cases. Sorry. So why? Because you can ask why you have went in an active phase. Because if we go in an active disease phase, the child dissections will be more common. So when you have a vascular changes in Takayasu arthritis, you have to see is there is an active inflammation or progression of a existing vascular lesion. Here in our case, there is a progression of the lesion. That is why child is on drugs, but still it was progressive disease and went into encephalopathy stage and seizures. That is the reason we escalated immunosuppressions, but still the child is in a progressive vascular lesion. That is the reason we have considered our interventional management, that is the balloon dilatation, with which child became better. So thank you.
Thank you, Dr. Bhargavi. It was excellent demonstration of, another case of treatable cause of LV dysfunction. So during the COVID era, we tend to diagnose all LV dysfunction as MIS-C, and we tend to give them IV gamma globulin. Sometimes cases like this, it would cause volume overload and on heart, and sometimes they can land up into pulmonary edema, flash pulmonary edema, and they may need actually intubation. So it is very important to carefully identify causes for left ventricular dysfunction and treat them accordingly. And when we don't find any reason for ventricular dysfunction, then probably depending on the inflammatory markers, we can consider them as a, as a messy case. And for Takayasu arthritis, there was a question whether it can present as a LV dysfunction. So probably we have around a dozen cases of Takayasu arthritis, and I want to tell all of you that they all presented as LV dysfunction. So there will be, as Bhargavi said, there will be central hypertension, and because of that, there will be first presentation would be like LV dysfunction. And once we relieve the obstruction, then they gradually improve. There's one more cause for central hypertension in these cases, that is the renal artery stenosis. So carefully, we should take Doppler of renal artery, or CT scan can pick up that. So wonderful case, Bhargavi. Wonderful case, Dr. Vinod. I'll take the questions because I'm seeing there are several questions here. So how were the carotid pulse volume, Bhargavi? That is one question.
Carotid pulses are also weak actually in this child. Left carotid pulses are weak, right we can feel.
Yeah, so I think if you don't find any pulse, better to palpate both carotid. You can also palpate temporal arteries in these children. And if you're palpating that, then you know that, the central pressure is high, but it is the peripheral obstruction of either subclavian artery, femoral artery. It's a large vessel disease. It can involve several arteries. And one of the commonest artery which gets involved is renal artery and a subclavian artery.
Actually, in this case, renal arteries were normal.
Yeah, so luckily in this case, the renal arteries are normal. Yeah.
I think
it's important to keep these cases on follow-up because it's a progressive disease. This is not one-time obstruction that you relieve. Again, because of the inflammatory process, there can be obstruction at the level of aorta, or the newer arteries can get involved. So they should be on follow-up. They should be on follow-up with rheumatologists also for anti-inflammatory drugs. And
I think an important thing is like we could not find all the pulses because the patient was in severe LV dysfunction. So this is an important thing is where if the child goes anywhere for an examination, need for a cold cough or some fever for unknown origin, it could be an underlying Takayasu. At that time when the LV function is good, if you palpate all the pulses, then you'll get some of the pulses being missed. So that will be easier to diagnose them earlier. It's always difficult when they come with an LV dysfunction. All the pulses definitely will be absent at that time.
Yeah, and also very important to extend your auscultation skills to abdomen. Like here, the bruit was there, which was missed initially, and renal artery bruit, auscultation at the back, because adult coarctation would have collaterals. So even sometimes adult coarct or like 17, 18 years, they may have extensive collaterals, which can be picked up only if you auscultate the back. So we should extend the use of stethoscope. It is still not outdated technique, and make use of it maximum in bedside cases.
And the ECG also. ECG
yes, I totally agree.
Especially when you have an LV dysfunction with evidence of LVH, you must always think of some obstruction in the aorta or systemic hypertension.
Yes, hypertension.
And what we get usually ECG for the audience, I would tell that in myocarditis, it will be low voltage QRS complexes. But whenever you find very high voltage QRS complexes and LV dysfunction, then think towards LVH obstruction, and then there can be hormonal causes as well. So if there are any questions, our expert speakers are here. We can take that questions. Anybody from audience or our expert faculty?
Subramaniam, sir.
In any child, it is better to feel the dorsal spadias of both sides, as well as radial artery and also carotid arteries routinely. Whether it is a cardiac case or this thing, many times will be successful.
Yes.
And also another important thing for a cardiologist or young postgraduates, I always say, always keep both hands on both sides of the chest. You never know when a child will have dextrocardia, etc. So it's better you touch the child as much as possible because child will not protest. Okay, so many times we can find out. Of course, though they are rare conditions, but it should not be missed by clinical examination. And of course, BP is very important.
Yeah, so wise words from you, sir. We totally agree with that.
Subramaniam sir. Dr. Subramaniam sir.
Are there
I'm
any
happy
more
to see Sangram
questions?
Chakravarti because I have listened to him so many times and he is one of the very budding cardiologists.
Dr. Yashwanth,
Yeah, if Dr. Subramaniam wants to speak, Dr. Subramaniam.
yeah.
Dr. Subramaniam. He's there in the audience.
Hello.
Yeah,
Yeah,
Subramaniam
we
sir.
can hear you.
చెప్పండి సార్.
మాట్లాడతారా సార్ Subramaniam sir?
Yes, sir. Currently, I think it is going on with non-specific obstructive aortic arteries. I could listen, sir. That case is interesting. Takayeshu, the one madam was presenting.
Yes, sir.
Actually, child had evidence of LVH and also failure, left heart failure with pulmonary edema. The case was presented. We are coming across quite a good number of cases of obstructive aortic arteries, especially in the adolescent girls and sometimes boys also. And on whom the peripheral pulses appear to be weak, actually child will be having, as said, the central hypertension will be there. But they carry usually a good prognosis or not in general. And what exactly are the outcomes? Long-term follow-up studies, did it reveal anything about what's that? That's I would like to know. Hello, am I audible?
Yeah.
Yes, you are audible, sir. Actually, these children, these adolescents and all, most of the time we have to be on follow-up with disease modifying agents. And most of the time they may need like repeated balloon dilatations, sir, depending upon the symptomatology.
And actually the process will be more or less an ongoing one, and there will be continuous process that will be going on. As you said, there is trials of anti-tuberculosis treatment also is there on children. I think, but more often they tend to develop complications like cerebrovascular accidents and others. So because it seems to be more progressive and refractory hypertension, I think.
Yes, sir.
So that's an interesting case. And the other case also, I think Madam Bhakru Madam has presented another case in a recent pediatric meet also. I think she has presented that one child. That's right. Okay. Thank you.
Yeah, chairpersons Sridhar and Lakshman sir, your comments.
Yeah, excellent case presentations from 3 cases from Vinod and Bhargavi and Pooja, and definitely excellently moderated by Swetha Bhakru. And I think these 3 cases had made all the viewing delegates very up to date for this knowledge of the cardiac cases. And thank you very much for all the participants, and hand over to President Yashowanth now.
Yes, Vamshi, you want to comment, Dr. Vamshi? Dr. Vamshi?
Yeah. So good that these PATS is conducting continuous education programs with very interesting cases and good faculty, and good that I could see all the senior people here. And I thank all the team, especially PATS 2023, to come up with this program. President Yashowanth Rao, myself, and the team members, I congratulate all. Thank you. I acknowledge the presence of all the senior members. Thank you. And over to you, Dr. Yashowanth Rao, sir.
Dr. Ramesh is there from Kurnool. He wants to comment. Dr. Ramesh. Vedantam Ramesh. Ramesh sir. And Mallikarjuna from Bangalore is there. Dr. Mallikarjuna from Bangalore. Thank you, Swetha ma'am, Dr. Vinod, for taking your time from busy Kovai Center. Then madam, I think she was attending a case before joining also. She was on ECMO. Bhargavi madam, Swetha madam, I'm the newcomer, Pooja Sinha. Thank you for all your inputs. Your cases were excellently moderated, as Dr. Professor Srinivasan was saying. Though you appear young, but you're rich in your investigative and approach. So it will help more of our people in arriving certain things. Thank you so much.
I thanks once again IAP for having us on this platform. We looking forward for more and more this kind of association. I'm sure by this kind of interaction, we'll learn from each other and we can give more benefit to the needy patients. I thank you, all of you.
Thank you, ma'am. Thank you.
Thank you.
Thank you.
Thank you, Sridhar. Thank you, Lakshman. Thank you, Srinivasan, sir.
Yeah, thank you, sir. Good night, all of you.
Thank you, sir.
Very instructive and very illustrative.
Thank you and good night, everybody.
Thank you. Good night.
Thank you, sir.
Thank you.